Welcome everybody to the annual Global Nursing Network for Rare Disease Symposium. It is the first of its kind that we are hosting. My name's Sharron Gannon. I'm going to be your host for this afternoon. And to let you all know that it is being recorded. So hello to everyone joining us live and hello to everyone on our YouTube channel. For the housekeeping of the evening, if you can please remain on mute while the presentations are being given. Please feel free to have your camera on. We love to see the faces, and to also access the chat function within Teams as well for any thoughts and questions that you have during the presentations, but there will be opportunities to ask questions at the end of each session. So we will move on. Like I said, if anyone has any issues, please pop them in the chat and I will be monitoring throughout. So as a global network, we respectfully acknowledge the Native, Indigenous and First Nations people on whose ancestral lands we gather around the world, as well as the diverse and vibrant cultures that they represent. So this is what our agenda looks like for today's session. We do have a packed few hours, and we have the privilege of listening to a few speakers from the network as well. So for our first session that is going to be running through the network and the strategic framework, we have Sue Baker, who is the co-founder of the Global Nursing Network for Rare Diseases and is also the program director for the Rare Care Centre in Western Australia. We have Pugh, who is the project consultant for the Rare Care Centre, and we also have Kaila Stevens, the network manager for the Global Nursing Network for Rare Disease, that will be taking us through the initial sessions for today. And then we have three presentations from three of our nursing members. We have a presentation from Emma, from Boston Children's. Unfortunately, due to time restraints and time zones, she was unable to be here herself, but she has sent a recording of her amazing presentation, so we'll be going through that later. We also have the wonderful Sharron Meadows from New Zealand, who will be presenting her speech, and also Aster Lynn from the Philippines that will also be rounding off the evening with her presentation as well. So in that order, we will hand over to Sue to take us to the next bit of the session. Thank you, Sue.
Thank you, Shan, and I'm delighted to be here. So hello, everyone. I'd just like to start by just talking a little bit about the inception of the network. It's very new. We founded the network last year in March when we brought together 33 nurses across 25 countries. We ensured that 50% of those countries were low and middle income. And we also engaged 8 global leaders. So together we co-designed the network because we wanted to ensure that the network would not only attract nurses, but also retain nurses once they actually were in the network. So the network is a global nursing community of practice that encompasses all rare and undiagnosed diseases. Because of the rarity of the individual diseases, we have to connect globally. We do not have an option. However, what we do know is that the experiences and challenges faced by people living with a rare disease are all the same. They're common. Therefore, we should be able to connect together to share common solutions. Why nurses and why a nursing-specific network? Well, nurses make up 50% of the world's healthcare workforce. And they're often the most accessible healthcare workforce, and often in some areas, the only healthcare provider available. And nurses are the main caregivers in rare disease. So they deliver care not just across the lifespan, but also across all aspects of rare disease care. So they're involved in screening, delivering therapies and treatment, providing health education, coordinating and navigating care, and providing counselling and emotional support. And because we are the main caregivers, we're often the closest to patients and families, and therefore we're in a very good position to advocate and be the voice of patients, which is why nursing needs to be strategically positioned to influence local, national and global policy and advocacy platforms and play that leadership role. And this is why we're here. and we want to benefit people living with a rare and undiagnosed disease. So we know that there is a lack of knowledge across all healthcare professionals about rare diseases. So we want to increase the knowledge and upskill nurses about rare diseases. We also know that there's a diagnostic odyssey that is very real, and it takes on average up to 7 years for a child to receive a diagnosis. So we want to identify children and adults earlier and get them on a diagnostic pathway sooner. Only 5% of children with a rare disease have access to a treatment that actually alters the prognostic pathway. Therefore, often their only chance of treatment or therapy is through a clinical trial. So we need to be helping to enable that access. And we know that people living with a rare disease have very high levels and burden of mental health. So along with stigma, isolation and discrimination, we need to reduce this through raising awareness and advocacy. So that really is our raison d'etre. So when we first founded the network, our first focus area was on promoting the network. Obviously, it was brand new. So our first priority was to launch a webpage and an online professional platform, which we launched in September 2023. We're also utilising social media to spread the word. So we have a LinkedIn page and a YouTube channel. And a number of the members have presented at various conferences in different countries and also published a couple of articles. A number of other rare disease organisations have reached out to us, and they have promoted our network as well through their own respective networks. So, for example, the Undiagnosed Disease Network International asked us to record a GNNRD video that went out across the world on Undiagnosed Disease Day this year. The Global Commission to End the Diagnostic Odyssey undertook a case study on the GNNRD and then published their report, which then led to further interest across a number of countries. And we provided some travel scholarships through the network. So the promoting is working. We have new members and new countries coming in every week. And we've never got to a point yet where this has gone static. We have 397 members to date from 47 countries. And every continent is represented. And I think this is actually an amazing outcome, considering, we launched the online platform less than 12 months ago, and the membership continues to grow. So I would encourage all members to keep promoting the network and encouraging other nurses to join. We say that this network is for all nurses. Nursing students can join, and it's for midwives too, and midwifery students can join, because all nurses and midwives will look after and care for people with a rare disease across their career, regardless of the area or the setting in which they work. So one of our other focus areas was on connecting the network. We were very conscious we were a new network, and there's already existing networks out there and organisations that have been there for many years doing excellent, amazing work to help people with rare diseases. So what we didn't want to do was duplicate any work they were already undertaking, and we just wanted to add value. So we are connected to some of the key global and national rare disease organisations through our global leaders who helped us initiate the network, and they've continued working and partnering with us to provide strategic direction and advice and maintain those connections to the key rare disease organisations. Also, because we're quite generic, we do need to connect to the disease-specific organisations to ensure that we are respecting the individual clinical and disease differences. We are also very focused on producing education programmes for nursing in the rare disease space and resources. So we need education partners and collaborations with academic institutions, because this is their area of expertise. We are in discussions at the moment with some other key nursing organisations to see how we can both each leverage each other's strengths and create something better together. And we're also connected to funding bodies. We do have funding for the network for a further 2.5 years, but we're looking at a longer term sustainable funding pathway. We're looking now to build the network, and it has gained a lot of momentum in a short space of time. And I think that's probably partly because it was a gap and it is needed. So a number of countries have reached out to us with an interest in establishing their own regional or country nursing network for rare disease connected to the GNNRD, and Aster are helping that. So we are partnering with Singapore to establish a national nursing network for Singapore, which we receive funding for, and also funding to establish an Asia Pacific regional group. Leaders in India and Brazil have also reached out, and we're looking to partner with them and progress those subsequently. The GNNRD is also being approached by other organisations from various countries to engage our membership, because, you know, we have a membership now that different organisations can either progress and spread the word around their initiatives to accelerate the impact, or to ask our advice on certain projects. So at the moment, we've got a survey going through the network, and we'd ask each of you to take a little bit of time to complete it. I completed it the other day, and it literally took me, you know, 8 minutes. So it's not burdensome. Some of the projects that we're working up in the Rare Care Centre here in WA, we're putting through the network. So, for example, we received funding to create an animated video to educate teachers, to help them to better understand and help pupils in their classrooms or their schools who have a rare disease. And so we're taking a global approach to that now, instead of just taking a Western Australia approach, and looking how we can interpret that and contextualize it to different countries. And part of the network's job is to showcase the impact and importance of nursing in rare disease. And a good recent example of that is in our second roundtable meeting that we held in May this year in Abu Dhabi, where we had nursing leaders from 15 low, middle and high income countries partaking in a variety of workshops. And you'll hear 3 of our members presenting at this symposium. But members presented their respective nursing roles, and this was predominantly a medical conference. And it was really moving to see the response from some of the medical fraternity in saying that they didn't realise this is what a nurse could provide, and that they needed to start thinking about engaging nurses in their multidisciplinary teams in rare diseases, because they were quite impressed with the scope of nursing practice and what can be delivered by the nursing profession. So it was really quite enlightening. The areas that we focused on for this meeting was developing the strategic framework that we're launching now, and more importantly, the actions to operationalise the framework. We did host 2 virtual workshops prior to this, and we're really grateful for the members that attended those. They were really interactive, and the members that attended were amazing with their feedback, giving their expertise and working this out together. So everything we do in the network, we are committed to doing in a co-design methodology. So we further workshop the strategic framework, and Dale, who I'd like to thank for the tremendous amount of work she's put into this and has led this work. I'll hand over to her in a minute to present it. We're also looking at how we create the structure and function of the national and regional groups or chapters, and also how do we accommodate the linguistic diversity within the network to ensure that global accessibility. We want to be truly equitable and accessible. We cannot provide everything in the English language. So I'm going to stop there. Thank you for listening to me, and hopefully that's just given a little bit of a flavour of the network. And I'll hand over to Dale. Thank you, Dale.
Thanks, Sue. Thanks, everyone, for joining us, and thanks to those who will be watching on YouTube. So our strategic framework, importantly, we have set that for 3 years. We decided we didn't want to put it too far down the track. It's important to be able to understand the work needed to be done relatively soon, and a 3-year period was deemed the most appropriate. So the framework, as Sue has mentioned, been developed with the staff that I work with initially. We put it out to members in 2 workshops, which was really, really helpful, and identified key elements that weren't missed but weren't front and centre enough. We also presented it at the Abu Dhabi meeting, and that again brought a tighter lens to elements that we needed to include. So it's a strategic framework, so it gives a vision to what we need to do, what we want to do, and a pathway to how we're going to achieve that. It is informed by our vision and our mission and our principles that you can see at the bottom of this page. So equitable access to care, cultural safety and responsiveness, and partnerships with patients and families. We have 6 strategic domains which we consider that will be enduring. So these are not going to change. And in saying that, they are fairly well grounded at a common sense level and in language that we see in our professional lives, in health services, and in global aspects of what we need to do. So education and learning, leadership and advocacy, we eventually decided went better together. Policy and practice go hand in hand. Research and innovation, collaboration and partnership, and growth and sustainability in relation to the network. Under each strategic domain, we have strategic goal or goals. Under those, then we have a number of priority actions. And in a separate document, we have a lot more detail around these that we can share if people need to. And then that will inform, where needed, a project plan. So for education and learning, clearly it was very well communicated by the members that we need access to bespoke educational programs and learning activities. And one of the goals is to develop an educational program. Leadership and advocacy is developing, supporting, and empowering nurses to lead for excellence in practice. And it doesn't matter in what position or at what level you are as a nurse, we all have capacity, capability, and a need to lead in whatever we do. We want to enable the recognition of rare and undiagnosed diseases as a nursing specialty, and we have some activities that will align to that. Guide and drive advocacy for rare and undiagnosed diseases and those people and their families and carers living with the diseases. For policy and practice primarily, and this allows us opportunity to be responsive in different ways to address that strategic goal, but we want to influence policy and promote practice that is evidence-based. For research and innovation, again, promote, support practice-based, priority-driven research and innovation, and promote, support, and design research that actively involves those people living with a rare undiagnosed disease. That is important, and you can see links to the collaboration and partnership. We need effective and strong collaborative partnerships, and early work has commenced in establishing a lived experience advisory group to be our partners, assist us to give voice to the world of rare and undiagnosed diseases. Again, that'll be a pool of people that we can pull on to guide our co-design and our collaborative efforts. Our growth and sustainability is important because we can't do any of this without being a strong, effective network that can move with the times and be resilient. We want to foster active, visible and an engaged membership. I won't read through all those priority actions, but suffice to say, we are committed to building relevant committees to support this work. Initially, it'll be education and learning and a research innovation group, developing a learning program for nurses at a novice to a more proficient level, developing associated resources, including databases of nurses, their interest and practice areas that we can identify and pull to assist us with work, looking at recognition and awards, working on particular specific patient pathways for that rare undiagnosed disease space. We do want to commence a research activity. That's important in terms of other work we need to do, but starts putting us on that global stage as nurse scientists. Developing our communities is ongoing and brings us to the lived experience and network impact model. What we did hear from people was the need to have the patient, the family more visible. So what we've arrived at is this impact model, which aligns to the domains, as we've previously seen, is encompassed, we've got a bit of blurring there, but not to worry, is encompassed by that lived experience concept and the power that comes from that. And going to the inner circles looks at how that impact needs to be visible to our consumers, our patients, our families and carers, and what we need to see in this collective model. All around that, again, is the notion of partnership and collaboration. This slide is an early depiction of the governance and operational structure. At the top, we have our Network Leadership Committee. Feeding into that is the Network Advisory Group. Lower level, my right to left, we're looking at, we have our Secretariat, which have a support role. We have our Lived Experience Advisory Group, which we are currently seeking membership, Research Innovation Committee and an Education Learning Committee. They will report to the Leadership Committee. And in the new space that's emerging, regional country chapters are either a lead position plus or minus a committee, and individual ambassadors giving voice to all that is important, feeding through that chapter. Thank you.
Thanks, Dale. Sharron, do you want to go to slide 22? Just keep going. These slides provide the detail that sits underneath the strategic framework, and we'll share that in the network and more broadly after the symposium, so that members can take a little bit of time to read through the plans for the next 3 years and what we're proposing we'll be focusing on. And then we're always very happy to take on any feedback or thoughts, particularly where people are very interested in being involved. So on the back of what Dale has just spoken about with the strategic framework, our priorities for the next year are outlined on the screen. So I'll just run through them and give you a bit of an idea of where we're focusing, and then we'll go talk about some of the areas that we will be asking members if they'd like to become more involved in the work that we're doing, and if they'd be interested in either taking on a leadership role or being involved in some of the work. So our first priority is establishing an education and learning committee and a research and innovation committee. And the first priority for the Education and Learning Committee will be on the learning program, as Dale mentioned. So that's rare disease nursing and midwifery specific education program that currently does not seem to exist. And the Research and Innovation Committee will set its priorities and will drive the focus of how we ensure that there is research embedded in the Global Nursing Network. Next, we're looking to operationalise the Lived Experience Advisory Group. So our applications for Lived Experience Advisory Group members are currently open. We have contacted patient advocacy organisations around the world and asked them if they would like to nominate someone or if they could share the application form with appropriate members. We've had a number of applications so far, and the closing date is the 14th of August. If anyone has an organisation that they think that we may not have contacted or they would like to learn more about that, then you can please do let us know. You can, when we come to the questions portion, or you can put something in the chat. But this will be really key to ensuring that everything that we do, all of the activities and initiatives that we undertake, has the voice of patients, families, carers, consumers at its heart. We want to ensure that everything that we're doing is in partnership with patients and families. We're not doing anything to patients and families, we're doing it in partnership. So this group will really provide us with the voice of our partners and ensure that they're at the table in all of our initiatives. Next, we're looking at how we implement solutions to address linguistic diversity. So one of the big challenges of being a global network is how to actually ensure that we are accessible to as many members as possible in languages that are going to be appropriate for them. So we're very conscious that so far we've provided the vast majority of our resources in English, and we're looking at how we can change that. So there are some opportunities to look at translating, live captioning, and things like that. As Sue mentioned, our big focus has been on starting to develop regional and country chapters and how we build local capacity. We know that things that happen at a global level may not be completely applicable locally. So how do we actually ensure that the work that we're doing globally can be translated into a local context? And equally, things that are happening locally, different initiatives, development of protocols, development of resources, can be shared with others, adapted to different contexts, and can mean that we use our resources more effectively. So we're not duplicating things that are already being done elsewhere, and we can share and work together more effectively. One of the first priorities for the Research and Innovation Committee will be defining nursing roles and scope of practice in rare diseases. We know in many countries there is not a specific rare disease nursing role, and some places are starting to become more interested in how to define that. So as the Global Nursing Network for Rare Diseases, it's a big, one of our priorities is actually providing a framework that we can, that other countries can use to actually start to influence what their nursing roles look like in this area, so that they're no longer a generic nursing role. Within the network and the functioning of the network itself, we're undertaking a review of the digital platforms and interfaces we use, such as the website, our Mighty Networks professional networking platform, our LinkedIn, YouTube, to actually make sure they're fit for purpose, that they're doing what we need them to do to support members to interact with each other and engage with the network. And as part of that, we're looking at implementing an engagement and communication strategy. So that's both how do we communicate with our members and make sure members have the opportunity to engage with us, for us to be actively responding to what members want, and also how do we communicate more broadly around the role of nursing in rare diseases? How do we communicate with other stakeholders, share the activities of the network, and bridge that gap that currently exists? From the feedback of our members who attended the virtual workshops to develop the strategic framework, one of the points that was highlighted was the need for a resource directory of nurses who have, and their area of expertise or clinical specialty, so that members are able to connect with each other across their geographic locations according to their different areas of expertise or clinical specialty. So that's another priority for the next 12 months. And lastly, we're looking at co-hosting a rare disease nursing conference in 2025. So that's still very much in the planning stage. We're still determining where that will be and who we will partner with. But as soon as we have more details, then we will let members know, because we think it's really important that we continue to provide opportunities to come together as a rare disease nursing cohort to actually continue to have these conversations, whether in person or online, to continue to progress this work. And so on the back of all of the work that we're starting to do in the GNN, we're now a year into the establishment of the network, and there's starting to be a lot of things that we can do. So as we've talked about, we're going to establish a number of committees to start to progress these individual initiatives. So we have a number of opportunities for members who are more interested to take a more active role in the network. And we would really love to hear from members who would be interested in any of these roles. The descriptions and the application forms will be available in the GNNRD platform in the next week or two. So firstly, we have the education and learning. We're looking for education and learning committee members, and they will be really crucial to driving the direction of the learning program. Research and innovation committee members who will set the priorities and start to undertake some of those research projects around rare disease nursing. We're looking to employ a senior nurse educator, and that will be a paid position for approximately 3 months, and that person will lead the content development for the education program. So that role can be quite flexible across location and country. But will be based on the person's experience and expertise in the area, but more details will be able to be found within the platform. We're looking to recruit ambassadors, so people who will be able to go and champion the Global Nursing Network for Rare Diseases in their local area, whether that be in their organisation, at their local university, in their local hospital, to talk about both the Global Nursing Network, but also more broadly about rare and undiagnosed diseases, and to raise awareness around the challenges of rare and undiagnosed diseases. These roles are quite flexible, and they can be, so depending on what would suit someone, they can be kind of adapted to fit that. Similarly, we're looking to recruit country and regional network leads. So they might be, if you might be able to provide information and connection within your country or region to various organisations who are doing work that aligns with the Global Nursing Network. They might be to recruit members within that country, to support dissemination of the different initiatives that we're doing, to feed back information that's happening within that country to the global level to inform work of the Global Nursing Network. And if it's appropriate, that might just be a lead, or it might be a lead with a deputy or a small committee that could support to run events or meetings, or to present at conferences or hold education sessions. So those roles can, as I said, can be quite flexible and look different from place to place, depending on what is appropriate for that country and the context and where they're at in their rare disease journey. And lastly, in our efforts to try and improve the accessibility of the network, we're looking for any members who would be interested in providing us with some translation assistance. So that might be checking documents that have been translated into a language they speak to ensure that they make sense, and to check for accuracy, or to directing us to different resources that currently exist in their language that we can share more broadly. So there's a number of different ways that we would really appreciate if anybody's interested in providing that specific translation assistance. So on that note, we would love to hear from you. Does anyone have any questions, feedback, ideas? we're very open to anything, to any thoughts or comments that you'd like to make. We're always very happy to make changes and to take feedback on board.
I think everyone is paused for thought. If any questions do pop up over the next course of the symposium, then please do pop it in the chat, or you can message us on the Mighty Network, so on our GNNRD platform, or you can email us at gnnrd.org or go onto our website, sorry, at gnnrd.org and get in contact us through that. The descriptions and of all of the roles in more detail will be available on the network over the next couple of weeks. So you will be able to get across what all of the roles are going to be looking like, bearing in mind, like Kaila said, a lot of them will be exceptionally flexible to fit to the person and their country. Likewise, please email us with any of the questions that you have about the roles and their responsibilities once they come out. And we will be more than happy to answer those, because we want you to be as involved as you can be. And if any of those roles take your fancy, then we would love to talk through any of the barriers that there may be between you and taking on that role and responsibility. So that will be coming to you. You also will give you a notification through the email system as well. So you won't miss when the roles come out. Don't worry. Regardless of where you are in the world, you will be able to see them and you will be able to put your hat in the ring. So what I might do, if there is no more questions for that section, I would like to thank Sue, Dale and Kaila for giving us a glimpse into the strategic framework. Like Dale and Kaila have also said, those documents will also be available for you to look at more detail, because there has been an exceptional amount of work done on breaking down that document to cover all of our needs for the next 3 years. And we would love, again, your feedback and your perspective from your position, but from your role and from your country as well. So on that note, we shall move into the presentation phase of the symposium, and I will be sharing a presentation from Emma Michl, who is a metabolic nurse practitioner from Boston Children's Hospital in the USA. Like I said, unfortunately, the time zone there didn't really match up for Emma, so she has kindly sent us her presentation recorded. So I will just stop sharing this screen to pop it over to the new one. If you will bear with me for just 1 second. Okay, hopefully this goes as well as I like it to, like it did in my practice. But we all know technology can get the better of us.
Hello, everyone. I'm Emma Michl. I'm a pediatric nurse practitioner that works in the Metabolism program within the Division of Genetics and Genomics at Boston Children's Hospital, located in Boston, Massachusetts, in the United States. And I'm thrilled to be able to present today for the first Global Nursing Network Symposium, and want to thank the organizers for inviting me and for allowing me to give this presentation virtually and recording it several days before, given that I'm unable to attend live due to time differences between Boston and Perth. And I look forward today to presenting on nursing and rare disease across the healthcare system, the Boston Children's Hospital Nord Center of Excellence experience. I have no personal financial disclosures to report related to this presentation today. And so before I dive into my presentation, I'd like to frame my role in rare disease care. So as I said, I'm a nurse practitioner within the Division of Genetics and Genomics at Boston Children's Hospital. This is where I care for patients with inborn errors of metabolism, attending to their care across the continuum, ranging from acute care to chronic care needs. I'm also a doctoral student working on my doctorate in nursing practice, and my proposed dissertation is focused on improving emergency care encounters for my current patient population. So rare disease, it's individually rare and collectively common. I have next some statistics and facts that are most relevant to the United States, but I think will really ring true across the globe for those listening to this presentation. So it's estimated that 25 to 30 million individuals in the United States have a rare disease, or that's 1 in every 10 individuals in the United States. Half of these individuals with rare disease are children. It can take over 3 years to receive an accurate diagnosis. Individuals with rare disease can face medical costs that are 3 to 5 times higher compared to individuals with non-rare diseases. Individuals with rare disease incur nearly half of all hospital costs in the United States, and 95% of rare diseases lack a U.S. Food and Drug Administration approved treatment. As I began to create this presentation, I wanted to better understand what the literature was showing in terms of rare disease in nursing. A quick literature review brings up thousands of potentially related articles, which can be challenging to navigate through when looking to identify specific needs. Additionally, most of these articles were disease-specific, which is another challenge given that there are over 7,000 rare diseases that we know about thus far, and so how can you always apply one rare disease to the other? As I was going through this, there was one article that stuck out to me, which was a scoping review by Lubzeriz et al., which sought to better understand the emotional experience of the diagnostic process of a rare disease and the perceptions of support systems. This article was particularly relevant as it was written by nurses and published in the Journal of Clinical Nursing. Some highlights from this article included that they noted rare disease is often underdiagnosed, and that this has been reported to have a deleterious physical and psychological consequence in both the patient and their families, especially when institutional support during this process is low. This review provided evidence on the emotional impact of the diagnostic process and during the communication phases of the definitive diagnosis. Healthcare systems and professionals must be strengthened in order to improve the information, training, and resources, and nurses play a key role in coordinating communication and follow-up of those patients and the families that are affected. So as I said, nurses really play an essential role in rare disease care. And given the genetic origin of many of these rare diseases, knowledge of genetics and genomics, as well as precision medicine, is an essential competency in nursing care, research, and education. The nurse has a fundamental role as often a nurse manager, being a link between professionals and solving basic needs of the patient. The nurse with their assignment of prevention and health promotion is fundamental in the development of autonomy for the affected individuals, and they can carry out really specific interventions that promote self-care, maintenance of daily activities of living, readaptation to the environment, and emotional support. And within the nursing role includes the nurse practitioner. And so as advanced practice providers, the nurse practitioner role can facilitate restructuring of service, removing barriers to provide accessible and affordable care, and coordinated communication between patients, their families, and all healthcare providers on the team. And research from that same scoping review that I highlighted earlier has shown that all of this can be done without jeopardizing the quality of care. While the individual nurse is really essential to the care for individuals with rare disease, large organizations are also needed to support these individuals. In the United States, a major one is the National Organization for Rare Disease. And their mission is improving the health and well-being of people with rare disease by driving advances in care, research, and policy. And the values include compassion. They're committed to understanding the perspectives and circumstances of others and strive to make a difference. Integrity. They're respectful, genuine, and accountable for all that they do. Innovation. They're passionate visionaries working to create a better future for the rare community. Inclusion. They foster a sense of belonging in community by seeking out and including diverse perspectives. And collaboration, where they work intentionally towards common goals and support others to reach their full potential. Within NORD, they have recently created the Centers of Excellence, which is the first of its kind network of United States medical institutions which are dedicated to diagnosing, treating, and researching all rare diseases. And the vision for this is that all persons living with a rare disease, regardless of disease, socioeconomic status, or demographics, have access to timely diagnosis, quality, compassionate clinical care, research opportunities, and supportive resources. So the program was officially launched in November of 2021 with the announcement of the first 31 designated rare disease centers of excellences. And currently there are 40 located within 26 states, including the District of Columbia, and they span across the United States, which you can see on the map here. And for perspective, Boston Children's is located there and is encompassed within the Harvard Medical School Center of Excellence. The NORD Center of Excellence at Boston Children's consists of multidisciplinary experts that are focused on helping patients manage their rare genetic diseases. It offers access to resources and care and strives to connect patients with specialists and programs who can help with diagnosis and management of their rare diseases. It's committed to high quality care and standardization, bridging different specialties across the network of centers, helping patients access quality care regardless of their location, ethnicity, or socioeconomic status, further closing the health equity gap. And this center is led by Olaf Bodemer and his team. So currently, the NORD Center of Excellence has a steering committee, which includes clinicians, researchers, and patients. Current activities include a newsletter, a speaker series, Rare Disease Day. There is ongoing development of a directory of rare diseases, and as well as a directory of programs and services. And now I've talked a little bit about the NORD Center of Excellence. I'd like to talk about the Greater Boston Children's Hospital System. It has a focus on patient and family-centered care. There are 11 locations, which includes the main campus plus 10 satellites, and this has 40 plus clinical departments. And then within those 40 plus departments, there are over 258 specialized clinical programs. 6 of these locations see patients that are followed in the genetics and metabolism programs. There's also ongoing research. The main one includes the Manton Center for Orphan Disease Research, as well as other more focused research efforts, often by department or disease. So nursing at Boston Children's is really essential to all patient care. The role of the nurse spans the entire care continuum, including acute to chronic, emergency care, inpatient care, outpatient care. And nurses are functioning in roles beyond the bedside. They hold positions in leadership, patient flow, operations, education, case management, safety, quality, informatics, and research. And there's roles at every level of licensure, ranging from a certified nursing assistant to a doctorate of nursing practice or a PhD, with everything in between, including staff nurses and advanced practice registered nurses. And there's a really notable structure for nursing advancement that helps to elevate the role of nursing within the institution. And of those 3 roles listed on the slide here, I've worked in each of them. So to focus a little bit more on my current role as an advanced practice registered nurse, nurse practitioners are providing care across the care continuum. Just like all the rest of the nurses, they function in the inpatient setting, the outpatient setting, emergency care, procedure units, and operative units. They work collaboratively on multidisciplinary teams, as well as independently care for patients and their families. There's been recent enhancement to the leadership structure for nurse practitioners at Boston Children's Hospital, and that includes lead nurse practitioners as well as directors. And the recommendations for this enhancement came to add value to the advanced practice registered nurse community through retention, recruitment, engagement, and optimization. And it aimed to build a system of enhancement through scope of practice, organizational modernization, and compensation standards. And they aimed to also align the APR and care delivery system with foundation structures through cost, outcome measures, and leadership structure. Currently, within the Division of Genetics and Genomics, there are 4 nurse practitioners, including myself. We practice in clinical genetics, metabolism, clinical trials, and basic research. And our day-to-days can all definitely vary greatly, but includes potentially spending time in the outpatient clinic, seeing patients both independently and collaboratively with MDs, providing inpatient care for our consultation services, performing care coordination activities, which there are honestly too many to list out, but may be related to medications, prior authorization, testing, and liaising with both patients, families, and community providers, and then performing necessary administrative tasks related to operations, process, quality improvement, and safety. So I think it's important to understand what's the impact of this nurse practitioner within the Division of Genetics and Genomics and for rare care. So my day-to-day includes, if it's an outpatient clinic, I can see up to 8 patients a day. Many of these have varying socioeconomic statuses, speak different languages, and have varying levels of health literacy. When I'm on inpatient service, I can follow a patient from their initial diagnosis in the outpatient setting and have a better understanding when they're coming inpatient, allowing me to provide improved continuity of care across the care continuum. And so this impact really is about access. I'm providing patients and their families access to care, especially due to physician shortages. Health equity. The nursing teaching model is one that is patient-centered, and so it's really poised to address health concerns. And then perspectives on care, which in turn improves patient care. And all of these impacts are truly interconnected. So how does nursing fit in within the Boston Children's NORD Center of Excellence? As the center's influence continues to grow, nursing is going to remain a constant across divisions and departments and spheres of care. And nurses are vital clinicians to the care team, especially for patients and their families living with rare disease. The nurse can really be that advocate, be that support person, and provide that really necessary care for these patients. And their connection to the NORD Center of Excellence is only going to elevate the care for these families. And so I'll end my presentation today acknowledging all the people that have really come to make this presentation possible. First, all the care team members within the Division of Genetics and Genomics at Boston Children's Hospital, Dr. Bottomer and his team within the Boston Children's Hospital NORD Center of Excellence, the leadership from the Global Nursing Network who's invited me here today. And then I want to thank all of you for listening to this presentation. These slides are originally from a live presentation that I gave at the Middle East and North African Rare Disease Congress when I was there with the Global Nursing Network. And so at that point, I had welcomed any questions or comments, but we'll ask that the team members from the Global Nursing Network share my email with those participating in the symposium today. And you're welcome to reach out to me that way if you have any questions about the topics that I've presented on. And I look forward to collaborating with everyone. Thank you, and hope everyone has a great rest of their symposium. Bye.
So I will slip to Sharron. Sharron Meadows is a neuromuscular nurse specialist from the Auckland District Health Board from New Zealand, and I will hand it over to you, Sharron, for your presentation. Thank you.
Thank you. So good evening or good morning or wherever you may be, and thank you for giving me this opportunity to present to you. As Sharron said, I work as a paediatric nurse specialist within the neurology department at Starship Hospital, and I'm responsible for providing specialist care for infants, children and young people with neuromuscular disorders. And I work within the Auckland region of the North Island, which is in New Zealand. I'm going to talk to you about rare disorders and my particular interest in neuromuscular disorders, and with the children that we look after, especially in our nurse-led neuromuscular clinics. I do not have any disclosures or financial interest with regards to this presentation. So as I mentioned, neuromuscular disorders sits under the umbrella of rare disorders, and here are a few facts and figures regarding rare disorders. So there are over 8,000 clinically defined rare disorders, with 72% genetic, and of those 70% start in childhood. That equates to 3.5 to 5.9% of the world's population. 300 million people in the world are living with a rare disorder, and in New Zealand, rare disorders are estimated to make up a total of 6% of New Zealand population. In New Zealand, we are currently developing a rare disorders strategy, which is designed to improve the lives of people living with rare disorders. And we have 300,000 people, living with a rare disorder in New Zealand. So moving now more specifically onto my field of nursing, which is neuromuscular disorders, which again is a rare condition that affects the functioning of the muscles, causing progressive muscle weakness. It affects approximately 10 million people worldwide, which is the same prevalence as Parkinson's disease. Neuromuscular disorders are not curable, but the symptoms are treatable. And 4 out of 5 cases of neuromuscular disorders are from genetic mutation. So paediatric neuromuscular disorders is encompassment of the spectrum of diseases where the primary abnormality or the lesion is in the peripheral nervous system. This is defined as including the anterior horn cell, the peripheral cell, the neuromuscular junction, and the muscle. And in our nurse-led clinics, we see children that are affected with spinal muscular atrophy, all types 1s, 2s, and 3s, peripheral neuropathies, especially Duchenne muscular dystrophy, congenital muscular dystrophies, late onset limb girdle, fascioscapular, and the myasthenia gravis and congenital myasthenia gravis syndromes. The most commonly we encounter a genetic disorder that we encounter is Duchenne muscular dystrophy. And going on, leading on from that, there was a study that was undertaken in 2015 to determine the prevalence of genetic muscle disorders with children and adults in New Zealand. Its results showed a age standardized minimum point prevalence of genetic muscle disorders was 22.3 per 100,000. The prevalence in Europeans was 24.4 per 100,000, which was twice that observed in New Zealand's other three main ethnic groups, being Maori, Pacifica, and Asian. There were considerable variations, regional variations in prevalence, although there was no significant association with social deprivation. But what I wanted to highlight to you from this research was one of the most prevalent conditions was Duchenne muscular dystrophy, and this would correlate to the amount of boys we see in our nurse-led clinics with this disorder. So I'll go on and talk to you about Duchenne muscular dystrophy and the models of care we use when caring for these children in our neuromuscular clinics. So Duchenne muscular dystrophy is the most common and severe muscular dystrophies. It affects predominantly males, and it equates to 1 over 3,500 boys. DMD is caused by the mutation in the DMD gene, resulting in absence of the dystrophin protein. The absence of this protein causes progressive weakness and muscle cell breakdown, which are gradually lost. It's a terminal disorder, and our main focus as clinicians is the management and the improvement of that boy's life. As you can see from this, it affects boys. Usually they're diagnosed before the age of 5. They're confined to wheelchairs by the age of 12, and most don't survive their mid-20s, and it affects all parts of their bodies, as you can see in this picture. So DMD also causes heart problems. And heart disease is their secondary leading cause of death in DMD after respiratory disease. And it's deficiencies in the dystrophin that will cause itself as cardiomyopathy. Latent cardiomyopathy can often be detected at the age of 6 years. And virtually all patients will have some degree of heart disease by the age of their 18th birthday. Our standard care guidelines, which we use in our clinic, is based on a major international consensus document setting out best practice for Duchenne muscular dystrophy. These guidelines were published in the Lancet Neurology Journal in 2018. And these guidelines were a product of extensive review process by 84 international experts in DMD diagnosis and care. And its document is a unique guide to expert recommendations on the care for all individuals with DMD. So depending on what age and stage of the disease in clinic, we will ensure that the child has been assessed and appropriately referred to the cardiology team in a timely fashion. We frequently undertake study sessions to the theatre team at Starship and inform them of the risks that are associated with any general anaesthetic prior to any surgery. The heart should be closely monitored by a paediatric cardiologist, as problems can occur without any symptoms. When we have a new diagnosis, we will refer to a cardiologist and ensure that they continue to be monitored every stage of their disease. The risk of developing scoliosis is high with DMD, but it is reduced by steroid treatment. So the impact of scoliosis and respiratory function, it limits the vital capacity, it causes asymmetrical inspiration and decreases chest wall compliance, it decreases tidal volume to dead space ratio, increases the risk of CO2 retention, decreases cough effectiveness, and deplaces the thoracic cavity and diaphragm. So with regards to the respiratory, we split that up into the different stages of the disease, being ambulatory, early and late, and non-ambulatory. And as you can see, the assessments which are carried out at different stages of the disease. In clinic, in our nurse-led clinics, we undertake a respiratory assessment, which encompasses ensuring that they're up to date with the immunisations, especially the flu vaccine and the pneumococcal vaccines. And respiratory complications are a primary cause when the boys stop walking and become more reliant on their wheelchair. We consider respiratory referrals to the consultants when they lose their ambulation, their forced vital capacity is less than 60%, they have symptoms of sleep disorder breathing, they have recurrent pneumonias, swallowing difficulties, or when they have their cough becomes weak and they have difficulties clearing their secretions, and also eating and drinking. So orthopedic complications that can come from this condition, the boys will suffer from long bone fractures. 21% of DMD patients experience fractures, and the most common cause of mechanism is that they will fall over. About half of the fractures occur among patients who are still walking, and osteoporosis is present in most patients, and bone mineral density begins early and continues to diminish with age. So with regards to genetically target therapies for DMD, since 2018, the US Food and Drug Administration have approved 5 genetically targeted therapies for DMD. Each approval was based on studies to increase the dystrophin level in the muscle biopsy, not on functional data, and research is continued to look at the long-term clinical outcomes. Clinical trials of novel therapies in DMD we experience is frustratingly slow for our families. The majority of compounds trialed don't reach clinical trials, and the drugs have costed up to date the US healthcare system more than $3 billion. Our families closely follow these trials, and for some it provides them a hope of early access to therapies. But as we see in many rare diseases, we are seeing an increased shift towards genetic and gene therapies, which ultimately become very high-cost medications. Barriers to accessing high-cost medications are real in many parts of the world. And I think we do increase this risk of disparity between countries worldwide. So with regards to DMD, the DMD gene is one of the largest genes in humans. As a result of the mutation in the dystrophin gene that disrupts the reading frame, in the dystrophin protein, which ensures the endurance of the muscles and cannot be produced. Exon skipping therapies currently develop a goal to restore the reading frame. They are small pieces of modified DNA or RNA, and their job is specifically hybrid to target exons and hide that exon from the splicing machine. The splicing process is to make an out-of-frame mutation into the in-frame mutation. So here are the few of the exon skipping trials being currently carried out by Scarpetta, and it deals with a AAV vector-based gene therapy, which is designed to deliver a gene encoding microdystrophin protein of the dystrophin protein expressed in normal muscle cells to all muscles involved in the pathology of muscular dystrophy. It's developed by Scarpetta Therapies, and it's the first genetic therapy to be approved, which was in June 2023 under the Acceleration Approved Pathway for the treatment of DMD in the United States, Bahrain, Kuwait, Oman, Qatar, and the UAE, and is not approved anywhere else in the world. Its indication is for children that are walking from the ages of 4 through to 5 years with a confirmed mutation in the dystrophin DMD gene. This company continue to have active trials looking at changes in the North Star ambulatory assessment. So we don't have that treatment in New Zealand, but what we do have is steroid therapy, which is a supportive therapy which we provide to our boys. Prednisolone is funded and deflazacort is not. And we recently started a nurse-led steroid clinic, which we are offering to all our DMD patients, ensuring that all these measures are undertaken. So the benefit of steroids, what is the evidence? It slows the decline in muscle strength and function. The boys can walk for longer, approximately 2 to 5 years longer. It decreases the need for surgical spinal surgery. It stabilizes their lung function. And the evidence suggests that decline in heart function is slowed, and it stabilizes lung function and improves their upper limb function. Creatine is another supportive medication which we use for our boys. It increases their muscle force by 10% in control when compared to controls. It improves their time to walk 10 meters and to climb 4 stairs. It increases their muscle strength and lean body mass. It's only effective whilst they're taken, and to date there are no known side effects. So as I mentioned, we provide a nurse-led multidisciplinary neuromuscular clinic, and this is region-wide clinic for children from the age of birth to 16 years who live in the North Island of New Zealand. Our referrals mainly come from GPs, paediatricians, and some from within our hospital from specialists. So the aims of our clinic are we provide specialist comprehensive multidisciplinary care in New Zealand for children with neuromuscular conditions. The care is coordinated across various medical disciplines. It's a one-stop shop for families and children, and allows them to be evaluated by different specialists. It reduced the families' multiple appointments, which is a heavy burden. And it provides proactive interactions and treatments, and it collaborates effectively with developing care plans for all these children that have complex care. I think this slide here just touches on the coordination of care and services that we provide at our neuromuscular clinic. It's important to know that a multidisciplinary care of patients with DMD is a crucial component of the management of their condition, and we ensure all patients have all the appropriate teams involved to ensure the best outcomes. We ensure that each individual child receives all the necessary referrals when they come into our clinic. So in New Zealand, it's important that we talk about our Indigenous population, our Maori Indigenous population, and the care we provide for them when they have these neuromuscular conditions. As you saw, we use a biomedical guidance for our care considerations, which is not appropriate care when looking after our Maori population. At Starship, we provide a Maori healthcare team who work with Maori children and their families and hospital staff to help improve their health outcomes. This team help with the coordination of their whānau accommodation. They provide social and cultural and advocacy services. The Maori team also work with ourselves, the clinicians and staff, to help the Maori children and their whānau during their hospital stay and also after discharge, and provide them with cultural assistance. When we talk about Maori health, we need to look at the 4 dimensions of Maori well-being, and should one of those 4 dimensions be missing or in some way damaged, a person may become unbalanced and therefore unwell. So when providing Maori healthcare, we need to be mindful of their physical health, their taha tiana, which looks at their physical growth and development. For Maori, the physical dimension is just one aspect of health and well-being and cannot be separated from the aspect of mind, spirit and family. Their spiritual health, which is their taha waiora, and this looks at health as it relation to unseen and unspoken energies and relates to who and what we are, where we have come from and where we are going. Their family health, which is their taha whenua, and understanding that the family provides us with the strength to be who we are, and the links to ancestors, their ties with the past, the present and the future. Understanding the importance of family and how they can contribute to illness and assist with curing illness. And finally, the mental health, which is the taha hinigaro. And this is a capacity to communicate, to think and to feel. Mind and body are inseparable to Maori. And this comes to the end of my presentation, and I thank you all for listening.
Thank you so much, Sharron, and thank you for jumping in last minute through my technical difficulties. I very much appreciate you for that. Does anybody have any questions that they would like to pose to Sharron after her presentation? Again, please feel free to turn your mics on or pop it in the chat. Dale, thank you.
Thanks, Sharron. Without, you know, breaching any cultural safety rules, do the Maoris have their own understanding of what causes these neuromuscular diseases? Is it, I mean, I get the model and all 4 components, but...
Basically, yes, they do. It's our Pacific Islander cultures that have a bit more of a difficulty understanding.
Okay.
But definitely the Maoris, yeah, they will. Yeah, and they always, yeah, and they're always amenable and they want to do the treatment, whatever they can for their for their boys. Yeah. Yeah.
Thanks, Dale. Great question. And obviously recognizing that in the global network, we have to consider a lot of cultures and Indigenous groups from around the world. So that's a great question. Thanks, Dale. Thank you so much. So I will swiftly hand you over to Aster Lynn, sir, who is the Supervising Nurse Project Development Officer for the University of the Philippines. Aster Lynn, thank you so much. To share with the global group, there has been some severe weather for Aster Lynn over in the Philippines. So I'm very grateful for your presence here today and appreciate you. So I'd like to hand over to you for your presentation, Aster Lynn.
Okay, let me share my slides.
Whilst Aster Lynn is getting her presentation, can everyone please take a moment just to pop in the chat where in the world you're joining from today? It's of great interest to us at the Global Nursing Network to see where everyone's from. Thank you, Sue. Australia. From Italy. Ciao.
Can you see it now?
Turkey. It's just loading, Aster Lynn. From the Netherlands. Hello. Great. Thank you so much. Go for it, Aster Lynn.
Okay, good afternoon, everybody. I'm Aster Lynn from the Philippines. I'm one of the nurses of the Institute of Human Genetics. My involvement in rare disease actually started in 1999 as a newborn screening nurse. And then eventually in 2005, I was assigned as the first nurse in the clinical genetics and research unit of my institute and the section of genetics of the Philippine General Hospital. I was also part of the secretariat of the National Technical Working Group of the Department of Health for newborn screening and for the Integrated Rare Disease Program. So currently, I'm here in Davao City, located in the southern part of the Philippines, overseeing the establishment and operation of the Center for Human Genetic Services here in Mindanao. So the establishment of the Genetic Center is actually is our effort to make genetic services accessible to our to the different parts of the country. Okay, so the objective of my presentation is I want to share the engagement of Filipino nurses in taking care of rare disease patients in the context of the National Comprehensive Newborn Screening System and the Integrated Rare Disease Program. So the outline of my presentation is I will give you a brief background of the National Comprehensive Newborn Screening System and the Integrated Rare Disease Management Program in the Philippines. I will also discuss the role of nurses in the context of these two programs. So just like the other nurses in the world. So I will also discuss the challenges in taking care of the rare disease patients and our current activities and what we want to do in the future. So in this slide, this is the milestone of the National Comprehensive Newborn Screening System. Actually, the newborn screening system started in 1996 as a study. So Dr. Padilla, one of we consider her as the mother of newborn screening, actually had been lobbying for the integration of newborn screening in the Department of Health. But unfortunately, they would usually ask the doctors lobbying for this, advocating for this program, if there is evidence that this that congenital adrenal hyperplasia and congenital hypothyroidism really exist in the Philippines. So true enough, after that study in 1998, in 1999, the Department of Health adopted this program as part of their child health program. And then in 2004, the newborn screening law was enacted. And then one of the highlights is the adaptation of the fee, under the Philippine Health Insurance Company, and hoping that, all members of the Philippine Health Insurance Company can be covered with the newborn screening fee. So in 2014, so we started with 5 disorders, actually, then 6 disorders. And then in 2014, we included maple syrup urine disease under the panel. And then in 2014, we expanded to 29 disorders. So, but the time in 2014, it was optional. Parents has the option to choose the panel or the ENBS panel or the 6 tests. So in 2019, finally, the Philippine Health Insurance Company covered the whole fee, for the new expanded newborn screening. So everyone now is mandated to screen all babies, with under the expanded newborn screening. So currently, we are now doing 29 disorders, 25 of which is actually part of the list of the rare disease. So this slide shows the functional chart of the program. The DOH as the lead agency of the implementation of the law, and NIH as its technical partner. So this also shows the major stakeholders of the program, which includes the 17 regional offices of the Department of Health, local government health facilities such as the provincial, district, and city hospitals, and the newborn screening facilities. So currently, there are 8,010 newborn screening facilities in the Philippines. So these are facilities that educates parents about newborn screening, collects newborn screening samples, recall patients with positive screen, and releases results to parents. So we also have 7 newborn screening centers in the country. So NBS samples are sent and tested in the newborn screening center located in the various parts of the country. And at present, there are 7. And soon, an additional 2 centers will be open soon. So there is also a newborn screening team in all regional offices. Okay, so this map here shows the 8,010 newborn screening facilities all over the country. Okay, so right now, the newborn screening system is screening for 29 disorders, 25 of which are included in the Department of Health list of rare disease. So what are the roles of nurses at all levels now? So the subsequent slides actually we will be showing to you the different roles of nurses in the various level of program implementation. So as mentioned earlier, all of the 17 regional offices of the Department of Health have their own newborn screening team manned by a physician and a public health nurse. So they conduct newborn screening orientation among local health government units, health facilities for the integration of newborn screening in the local healthcare delivery system. They also conduct training on newborn screening and sample collection. They monitor and evaluate newborn screening facilities, and then assist in the recall of patients for confirmatory testing, long-term care, and patient navigation. They also assist in the distribution of medical food and orphan products, conduct parents forum for families with diagnosis of children, lobbies for budget allocation for the implementation of newborn screening in the region, so such as patient support, trainings, multidisciplinary clinics, and reunion of safe babies. So they also, yes, as mentioned, they also assist in the newborn screening continuity clinic in all its activities, such as the conduct of regular multidisciplinary clinic. So nurses are also involved at the newborn screening facility now. So these are community and community and hospital-based facilities. So usually each hospital, or whether it's a hospital or a rural health unit or health center or a line center, they have a team of, they have a newborn screening team composed of doctors, midwives, and nurses. So what do they do? So they educate patients regarding the importance of screening. They collect samples, they handle and send samples to the laboratory, and they recall patients for confirmatory testing. So from the newborn screening facilities, samples are now sent to the newborn screening center. So the newborn screening center is actually the laboratory site where testing are being done, and they have a short-term follow-up. So nurses there recalls and facilitates the confirmatory testing of patients with positive screening, and then they refer patients to specialists for further evaluation and final diagnosis, and eventually they endorses confirm patients to the newborn screening continuity clinic for the long-term care. So these are just some examples of our nurses in action. So some of them are collecting samples, recall patients, do the genetic counseling, networking with the Air Force. So like, for example, during the pandemic, you might be surprised how were we able to, continue the screening, and at the same time, how were we able to distribute our medicines, during the pandemic. So we partner with some military personnel and airlines, just to send our samples, recall our patients with positive screen, and send also our medicines and orphan products to our patients. So actually, even during the pandemic, there was no major disruption. So in these slides, it shows the treatment network of the program. So confirming the diagnosis is actually done by the short-term follow-up team of the newborn screening center. As soon as they confirm the diagnosis, they endorse these patients to the newborn screening continuity clinic for the long-term care of the patients. So actually, the newborn screening continuity clinic was established in 2014 in response to the during the 10th anniversary of the newborn screening, we tried to contact some of our patients. And then we saw, or we realized, that some of them are not going to the doctor for their continuity care. So, for example, we have a congenital hypothyroid patient. So at 10 years old, the development was really, it was far from the normal development of a child. So some of them have stunted growth, some of them are mentally retarded. So that's the reason why the program started to establish the newborn screening continuity clinic in 2014, hoping that these patients can be seen regularly for continuity care. So in 2014, we started with 14 tertiary referral government hospitals. So these centers are strategically located in the various parts of the country. Just last year, we expanded to 33 newborn screening centers. So what are the involvement of nurses at the newborn screening continuity clinic and the satellite clinic? By the way, aside from the newborn screening continuity clinic, we also established satellite clinic to be more accessible to our patients in the most far-flung areas, or we call it the geographically isolated areas. So right now, we also have another 33 additional satellite clinics. So just recently, we went to one of the farthest islands in the Philippines. We were actually convincing people to establish their own satellite clinics to make the continuity care more accessible to our patients living in the far-flung areas. So what do the nurses usually do as a newborn screening continuity clinic nurse? So they ensure the treatment adherence through the regular follow-up. So they call patients. They, for example, if these patients miss their regular follow-up, they call them. Sometimes they will ask the local government to fetch the patients and then send them to the to the community clinic centers. So they also provide long-term patient care and referrals to the needed specialties. Like, for example, they coordinate with local health facilities for consultations or telemedicines, facilitates referral to the social welfare agencies for psychosocial and financial assistance, especially for indigent patients. Unfortunately, 98 of our patients with rare disease belong to the poorest of the poor population. So they coordinate with the regional DOH offices for financial assistance and distribution of medical foods and medicine. So they also do home visits for the lost to follow-up patients. And then they conduct regular reunion of safe babies together with the Department of Health. The newborn screening continuity clinic is actually manned by one pediatrician and a nurse. Okay, so these are just an example of some of our newborn screening continuity clinic nurse. No? So they do multidisciplinary clinic. They conduct an annual reunion of safe babies. They conduct face-to-face consultations. They conduct home visits and teleconsultations, particularly for those patients in geographically isolated areas. So at the Center for Human Genetic Services, so we also have a group of nurses. No, actually, most of all of our nurses from the Center for Human Genetic Services is actually part of the GNNRD core group of the Philippines. No? So CHGS is composed of geneticists, genetic nurses, genetic counselors, metabolic dietitians, social worker, pharmacist, and administrative support team. So it was established in 2020 to fill in the gaps in the long-term continuity care of patients, especially in the management of IEM patients. So our nurses at the Center for Human Genetic Services manage cases. So they provide acute and long-term assistance to the newborn screening treatment network for clinical evaluation, management, multidisciplinary clinics, referral to specialists, and other allied health services. So they also spearhead staff development activities. So they initiate and spearhead learning venues for the newborn screening stakeholders, particularly nurses. Now, so we also conduct learning hours. We also conduct seminars and workshops. And then they also manage data or patient registry, because our institute is actually the repository of the registry for rare disease patients. So in addition to the roles mentioned earlier, our nurses also participate in research and development activities, so related to patient outcomes, clinical trials, and drug development. They also do networking and advocacy work with both government and non-government agencies. They provide guidance to patients and family support groups. They provide local access of orphan drugs and products to patients. So our institute, actually the nurses leads this, no? We procure and facilitate importation of the orphan products. No? So we are also responsible in distributing this to the different parts of the country. We do inventory and we manage the storage of these rare disease products. So to sum up, the newborn screening, the National Comprehensive Newborn Screening System, right now we have 8,010 newborn screening facilities. We have 7 newborn screening centers, laboratory short-term follow-up. We have 17 newborn screening team at the Department of Health. We have 33 newborn screening continuity clinics. So we have 20 satellite clinics. Actually, we now have 30. And then 3 Center for Human Genetic Services. In all these levels, we have a nurse or nurses doing the different roles. Okay, so these are our current prevalence of the diseases included in newborn screening panel. Unfortunately, I cannot see it well, but we can share it later. Okay, so let us now go to the Integrated Rare Disease Management Program and its highlights. No? So the Integrated Rare Disease Management Program of the Department of Health was actually in response to the Rare Disease Act 10747 or the Rare Disease Act of the Philippines. So rare disease is defined in the Philippines according to the disease prevalence of 1 is in 20,000 population, and estimated that 6,500 Filipinos are affected. So it aims to improve the access to diagnosed rare disease patients and highly suspected of having rare disease patients to comprehensive medical care, including drugs and other health care products to treat and or otherwise, as well as timely health information to help them cope with the condition. So we started with 55 rare disease, but last year, the Department of Health expanded this to with other disorders. So right now we have 159 rare diseases listed in the rare disease and the Department of Health RD list of disorders. So this is the strategic framework of the Integrated Rare Disease Management Program. So it envisioned that to provide optimum health outcomes for Filipinos with rare diseases. So the guiding principle is to provide timely access, provide comprehensive, integrative, and sustainable care, evidence-based and responsive, and inclusive communication. Okay. So we are hoping that these are the objectives of our IRDMP strategic framework. So objective number 1 wanted to integrate comprehensive care for persons with rare disease within the public healthcare delivery system, provide persons with rare disease access to entitlements and benefits, create health promotion and public information education campaign in rare diseases, provide evidence for policy and program planning through research and development, and then increase availability and access to orphan drugs and products, and persons with rare disease will have financial assistance. So hopefully with this framework, we will be guided on how we can expand more our services to patients with rare disease. So these are the engagement of nurses in the rare disease patients. No? So in addition to the newborn screening roles. So so this is one of the highlights in the rare disease law. So all newborn screening continuity clinics are mandated eventually to be the referral centers for rare disease patients. So for disorders not included in the rare disease panel of disorders, all of rare disease patients can be now referred to the newborn screening continuity clinic. So at the Clinical Genetics and Research Units of the Institute of Human Genetics and Philippine General Hospital actually is the largest tertiary referral center in the country. So our nurses are involved in patient management. So they are involved. We also conduct regular multidisciplinary clinics for some disorders, such as, for example, our Hunter syndrome, galactosemia, maple syrup, and many more. So we also conduct enzyme replacement therapy of patients with lysosomal storage disease. So we have actually 2 types now. We have the hospital-based, and we all just during the pandemic, we already started doing enzyme replacement therapy at home, in one of our patients with Pompeii. So they're also involved in data management or rare disease registry, and then, of course, they're involved in patient navigation. So our nurses also are involved in research and development. So like, for example, as mentioned earlier, so patient outcomes, clinical trials, and drug development. And then we also serve as the secretariat of the DOH National Technical Working Group of the Integrated Rare Disease Management Program, and we are very much involved in networking and advocacy. So actually, our institute is a partner of the 2 national programs of the Department of Health. So this is the newborn screening program and the Integrated Rare Disease Program. So what are our current activities? So of course, aside from patient management, we also do capacity building activities, upskilling nurses in managing patients with rare disease. So we conduct seminar workshop in collaboration with the Newborn Screening Reference Center. We also have 3 years ago, we conducted a seminar, workshop on genetic nursing. So we hope to repeat this again in the coming years, in the coming months. Then nurses, and then we also have regular cluster audits. So during this cluster audits, we do this monthly actually. So during the cluster audits, we discuss the different cases. So this is a good venue actually where nurses and doctors can, share their experiences in taking care of patients. We also have our metabolic specialist to guide them, no, or to assist them. So one of the things we also do is that during these audits, we also discuss some experiences of nurses in handling our patients with rare disease. So we also have learning hours. So this is usually we do this every 2 months. And then of course we have this mentoring, and then some of our nurses participate in local and international conferences in genetics. So we also develop IEC for patients and rare disease medical team. We also do monitoring and evaluation. And then 15 years ago, Dr. Padilla and one of our team from the Institute of Human Genetics, we organized a youth network advocating for patients with rare disease. No? So we call them the Volunteer Youth Leaders for Health. They help us in lobbying for the passage of the rare disease bill, and then they were able to gather 50,000 signatures in support of the rare disease. No? So we actually, there are partners in advocating for patients with rare disease. And then we also partner with the Philippine Society of Orphan Disorders, and then also with the local and national government, the Center for Health Development. This is the regional counterpart of the Department of Health, and other support organizations. So our challenges, so I think just like other nurses in the globe, we don't have local nursing guidelines for the existing rare disease. We have 176 ethno-linguistic groups. So one of our challenges actually is language barrier. So it's affecting the continuity care of our rare disease patients. So our nursing leaders need to increase their understanding about rare disease. So hence, there's no policies in support to nurses currently handling rare disease patients. Extensive information regarding the management of rare disease are not included in the nursing curriculum. So we hope to do this together with the GNNRD. We are really thankful for GNNRD. So we don't feel that we are alone. So we are part of a global community, taking care of this. So thank you for inviting the Philippines to be a part of this network. So hoping with the GNNRD, we can capacitate nurses for rare disease through continuing education programs, development of educational, information, and communication materials, and probably in the future nursing guidelines. So we would like to organize Filipino nurses for rare disease. So slowly we are actually feeling the reality of this dream. So probably after that, we can finalize all our strategic plan and can come up. So we will be aggressively organizing and recruiting members in the next few months. So we would like to network and collaborate with nursing professional societies for the inclusion of rare disease in the nursing curriculum, and hoping that in their continuing education programs, such as conferences, they can include some topics on rare disease. So just a take-home message, genetic programs such as the newborn screening and rare disease is a good venue to engage nurses in taking care of patients with rare diseases. Nurses definitely are vital members of the multidisciplinary care team for rare disease patients. We are actually the frontliners. So the increasing number of rare disease patients requires nurses to be equipped with necessary competencies to respond to the holistic needs of patients. So the need to educate, capacitate, organize, advocate, and mobilize nurses for rare diseases and undiagnosed patients should not be done later, but it should be now. So I think with the GNNRD, so we can collectively act as one. So because I believe nurses truly care for rare. So thank you so much for the organizers for inviting us to share our experiences. And then maraming salamat or thank you for listening, and mabuhay tayong lahat, which means long live all nurses globally who care for rare. Thank you so much.
Wow, 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 wow. Thank you so much, Astelin. That presentation was phenomenal. I feel like your presentation just shows how influential nurses are and can be, and what an integral part of the healthcare system that nurses are as well. Your stats for your newborn screening and your clinics are amazing. Just commend you and your team's work for that. Those numbers are really extraordinary. Does anyone in the room have any comments or questions for Astelin from her presentation or around her work in the Philippines in general? I have a question while people are thinking. Astelin, with your the continuity clinics, do the families engage well with those after their newborn screening?
Yeah, yes, actually, we have the Reunion Safe of Babies is actually a venue for parents to be involved, no, in the management of patients. And then we have the Philippine Society of Orphan Disorders. So the Philippine Society of Orphan Disorders was actually also organized by our institute, by Dr. Padilla also. So they have a regular meeting, and then they also have their own group chat wherein, together actually with some of our nurses, so they can actually suggest whatever is good for their children. The Philippine Society of Disorders, together with our institute and with our group, actually is doing regular activities. So yeah, that's it.
Yeah.
So yeah, we are hoping
Yeah.
to involve them more. Mhm.
Yeah, it sounds like a really collaborative approach that you have with the families, which we all know is super important, especially for our rare patients and families to assess their needs. I've actually got a question in the chat for you from Dion from Perth. If a patient has a rare disease that is not currently on your list that you showed, can they still access the service through the Center for Human Genetics service?
Yes. Yes, because we are catering to all genetic disorders. So it's precisely this is the reason why we are putting up all these centers, satellite centers, the different parts of the country, because we really wanted our services to be more accessible. So just to share you an experience last year. So because of our presence here in Mindanao, some of patients not included in the rare disease, actually when they knew about us, when some of the doctors, especially in the provinces, knew our presence, we now receive referrals actually.
Wow, great. And that just shows the power and importance of connection and collaboration and promoting the service, because potentially those families wouldn't have been referred in the past. So that's great to hear. That's amazing. What an achievement. You should really be proud of your service. It's great. So the third and final presentation from Emma has plagued us. So we will be adding it in after the fact. So please head over to the YouTube channel once we finish today's meeting to see the presentation from Emma. And I apologize profusely for our technical issues, but the presentation from Emma will be available to you all once the video is up and running. On that note, I'd just like to share my screen again So I would just like to say on behalf of the Global Nursing Network for Rare Diseases, thank you all for your attendance today, both here live in the session and for those viewing on YouTube. We really appreciate your presence, your knowledge, and sharing your experiences with us and with those around the world. We just would like for you all to keep sharing and to keep connecting both within the network and to bring those nurses that are around you into the network because of how important the message is around rare and undiagnosed diseases. After today, you can obviously still connect during through the network, sorry. For the Global Nursing Network, you can Google it. It's GNNRD.org. You can also use the hashtag, the QR code, sorry, on the screen at the moment. And we also have our LinkedIn for those that do use LinkedIn, where we share some newses and some new articles, and we post surveys and questions and things as well for those that have it. We will, like we said previously, be sharing all of the new roles and upcoming opportunities on the network, so please keep an eye out for that. If you have any other questions, feedback, or any ideas that you'd like to share with us, please send us an email at hello@gnnrd.org, and we will get back to you as soon as our team can. Continue doing the great work that you're doing. Continue sharing the message about rare and undiagnosed diseases. I hope you all have an amazing rest of your day, whatever time of day it is where you are. And we will see you at the next event for the Global Nursing Network for Rare Diseases. Thank you all. Take care, and we'll see you soon.